Good afternoon, and thank you for joining us. Welcome to NCSL's webinar, Chronic Disease Management During COVID-19. My name is Kate Bradford. I'm a research analyst in NCSL's health program, and I'll be your moderator for today. Before we get started, I want to review a few housekeeping items. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through polling and the chat box, so please feel free to type in any questions you have at any point during the webinar in the chat box on the left-hand side of your screen. We will hold a formal Q&A after our presenters are finished presenting. To begin building some comfortability with the chat function and to learn who is on the line today, I invite you to type in the state from which you are calling now. Above the presentation, you will see a few tabs with one labeled Resources. Here you can find and download a PDF version of the PowerPoint and a resource handout NCSL staff have put together. Another tab is labeled Speaker, where you can read the bios of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is being recorded and will be available on NCSL's website within the week. NCSL is the bipartisan organization that serves legislators and legislative staff in each state and the territories. We provide research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues, and we are an advocate for state rights in the American federal system. NCSL does not advocate for any policy, nor do we take positions on state issues. Now let's get back to why we're here today. Prevention, early detection, and routine care are fundamental components of chronic disease management. During the COVID-19 pandemic, the number of people being identified with and seeking care for chronic conditions has declined alongside a decrease in routine care and emergency department visits. Emerging data highlights the impacts of delayed care on long-term health and healthcare systems and the increased risk of severe outcomes from COVID-19 among those with chronic conditions. Today, we will have a discussion with national experts about chronic disease management during the pandemic and an overview of related state actions. I would like to take a moment to thank Amgen, an NCSL Foundation member supporting our work around women's health, health equity, and chronic conditions. Amgen's support allows us to provide up-to-date and relevant educational resources for state legislatures and webinars like this. Today, we'll hear from Dr. Susan Consagra, who will provide an overview of chronic disease and COVID-19. Then we'll hear from Dr. Keith Ferdinand, who will share information on the impact of COVID-19 on cardiovascular disease management and cardiovascular complications of the virus. Last, we'll hear from NCSL expert Jack Pitzer, who will provide a look at state actions and examples during the pandemic to address telehealth access and coverage. First up, we will hear from Dr. Consagra. Dr. Consagra is the Section Chief of Chronic Disease and Injury for the North Carolina Division of Public Health, where she oversees public health initiatives related to chronic disease, tobacco control, cancer prevention, injury prevention, and the public health response to the opioid crisis. She is currently serving as the board president for the National Association of Chronic Disease Directors. Dr. Consagra, thank you so much for joining us today. The floor is now yours.
Great. Well, thank you so much and for that introduction, and thank you also for the opportunity to present today. Really appreciate NCSL focusing on this really important issue, and thanks to all of you joining today. So, as mentioned, I'd like to give a brief overview of the impact not only of COVID-19 on chronic disease, but actually also the opposite, the impact of chronic disease on COVID-19, so both of those things. And to start off with, just to give you an introduction into chronic disease, about 6 in 10 adults in the U.S. have chronic disease, and about 4 in 10 adults have 2 or more conditions under chronic disease. And that is a broad, umbrella term, covers many different things. But some of the diseases that are considered chronic disease are those things like heart disease, cancer, lung disease, diabetes. You can see a number of diseases listed there. And the factors that drive those diseases are oftentimes risk factors like tobacco use, poor nutrition, lack of physical activity. So that's, when we talk about chronic disease, that's the overarching, umbrella term, and these are some of the things that are considered chronic disease in the U.S. Now, specifically, when we think about the impact of chronic disease on COVID-19, we know that there has been a lot of emerging data over the last 6 months, and we are seeing that chronic conditions do place individuals at higher risk of COVID-19 associated hospitalization and subsequent poor outcomes. If you look at the circles in orange, you'll see specifically the increased risk of hospitalization from COVID-19 with any one of those conditions. So, for example, with asthma, individuals have a 1.5 times higher risk of being hospitalized. With diabetes, you can see a 3 times greater risk. And if you look over on the very right hand, you'll see that individuals that have 3 or more conditions have a 5 times greater risk of being hospitalized. I mentioned on that previous slide about 40% of individuals have 2 or more conditions, and you'll see there also with 2 conditions, that puts a lot of individuals at a 4.5 times greater risk of hospitalization if they were to get COVID-19 compared to people without those conditions. So obviously puts individuals at a much greater risk of those complications. In addition to those specific risk factors, there's also great disparities in those conditions themselves among individuals, and also what we're seeing with COVID-19 outcomes. So just to give you some data there from the CDC, if you look across different race and ethnicities, including American Indian, Alaskan Natives, Asians, African Americans, and Hispanic or Latinos, you'll see that the case rate of COVID-19 is much higher in those populations, and there's many reasons why that could be, but what's striking is really the disparities. If you look at also hospitalization rate, we'll see a 4 to 5 times higher rate of hospitalization. There's deep disparities that not only underlying, again, COVID-19 hospitalizations, but really also in chronic conditions and disparities in access to treatment and other things that may be creating this broader disparity we're seeing with just this one issue. But that is true of all chronic disease as well. If you look at North Carolina data specifically, where I'm from here, we're not seeing anything too different from what we're seeing in the national picture. But in North Carolina, if you think about those that have chronic conditions, plus those over age 65, which put individuals at greater risk, that really is half of our population in North Carolina have those specific conditions I mentioned above that put them at risk of severe illness. So again, very broad impact that chronic diseases do have on the population and the prevalence of those. The other way that we are seeing the intersection between chronic disease and COVID-19 play out is in delayed care for chronic disease. So about 40% of U.S. adults have stated that they have avoided medical care over the last several months due to the pandemic and due to concerns of contracting COVID-19. And this includes also delays in urgent and emergency care, as well as just delays in routine care. And specifically, if you look at those with 2 or more underlying conditions, about half of individuals reported delaying care. When you look at those that do not have insurance, about 40% reported delaying care, and that was twice the rate of those with insurance. And you'll see some other demographics there as far as who is delaying care. And certainly that delay in care has implications. So, for example, if you think about heart disease, that obviously has implications. If you're delaying seeking care for a heart attack, you obviously will have greater damage to your heart muscle, increased risk of heart failure. If you're delaying routine screenings for cancer, that delays early detection and can lead to greater tumor progression, decreased rate of survival, and diabetes, increases the likelihood that you have poor diabetes control, and increases subsequent complications from diabetes like kidney and eye disease. So obviously delays in care are also a consideration. We want people to be safe and practice social distancing, but also to think about where they do need care and try to facilitate access to care. that is necessary. Just to give you an example of what we're doing in North Carolina, these are examples of 2 resources that we have for individuals. So, for example, continuing to encourage those things that we know help reduce the risk of chronic disease and help improve. So, for example, information around quitting smoking and the impact of smoking on COVID-19, and we know that there is real risks and connection there. And then also thinking about how we delay progression to chronic disease. So, for example, for individuals that have prediabetes, which puts them at risk for diabetes, working to connect them with diabetes prevention programs that are offered online. Is just 2 specific examples across many different things that we're doing in North Carolina. In addition, obviously, through our Medicaid program, we are working to increase telehealth provisions, have made over 125 different flexibilities available so that individuals can still get access to the emergency care or routine care that they need during the pandemic, and to facilitate different ways in which individuals can do that with their providers. Going back to some of the data on chronic disease, I mentioned oftentimes chronic diseases are other preventable risk factors. And on the left, you'll see a list of what those preventable risk factors are. I've already mentioned a few, like smoking, for example, high blood pressure, physical inactivity. These things drive chronic disease. And the one other point I would make is that when we think about those chronic conditions, chronic disease not only increases the risk of complications from COVID-19, but it's really important for a healthy population overall from any health threat. You want your population to be as healthy as possible, and chronic diseases are really the number one contributor to decreased mortality and morbidity in the U.S. And so anything we can do to improve chronic disease will have a number of benefits, whether that's improving, again, outcomes from COVID-19 or preparing our population for another health threat, in addition to the inherent health threats of chronic diseases themselves. This is a really important place to focus on. And when we think about those preventable risk factors, there are many things there that individuals can control, but there are a lot of things there that also are really dependent on the environment around individuals. And so how we support individuals in having a healthier lifestyle really goes back to the resources around them. And so that's where we tend to classically in public health think about this public health pyramid, where there's things that you can focus on at the top of the pyramid, which are very individual focused, for example, education and counseling around nutrition or physical activity or smoking, and clinical interventions you can do in that clinical setting. But then there's also upstream things. So, for example, if you look at kind of further down the pyramid, layer 4, how you change the context to make sure that those healthy behaviors are really the default option and the easier option for individuals is also really important. For example, thinking about how you have policies, for example, that smoke-free laws that really help promote tobacco-free living also reduces chronic disease. And so this is just another example of ways in which we can help prevent and reduce chronic disease in our population. Lastly, I'll leave with a few resources. These are 2 things that are created by the National Association of Chronic Disease Directors and really focus on chronic disease and COVID-19, and really more a individual-centered resource sheet for those that want additional resources, and you'll see a link there. And then also the role of chronic disease programs and how chronic disease programs are playing a role with the COVID-19 response. So I'll close with both of those, and I'm happy to take questions at the end of our session. So again, really appreciate interest in this, and look forward to more discussion for the end. And I'll turn it over to Dr. Ferdinand, who I believe is speaking next.
Great, excellent. Thank you so much, Dr. Consagra, for such a great presentation. And actually, just before we move on to Dr. Ferdinand, we are going to put up a brief poll for the audience. And the question is, which of the following has posed the greatest barrier to primary care during the pandemic in your state? So hopefully you all can see that up now. Please select just one answer here. And if you don't see the answer that would best apply listed, please go ahead and just type your answer in the chat box. So we'll give everyone just a few moments to select answers now. And as a reminder, you can put in any questions you have in the chat box, and we are compiling them for Q&A at the very end. Great. Thank you, everyone, for answering our survey. It looks like the most selected answer is A, patient concern for contracting COVID-19. So, exactly aligning with Dr. Consagra's remarks. So thanks again for participating in that. Next up, we have Dr. Ferdinand, who is a professor of medicine at the Tulane University School of Medicine and serves as the Gerald S. Berenson Endowed Chair in Preventive Cardiology. Dr. Ferdinand focuses largely on cardiac risk factor evaluation and control, especially in communities of racial and ethnic minorities. And he serves on the COVID-19 Health Equity Task Force in Louisiana. Dr. Ferdinand, thank you so much for joining us today. I'll hand it over to you. Dr. Ferdinand, I wonder if maybe you might be on mute. I think we are having trouble hearing you.
Thank you very much. I'm going to discuss some of the cardiovascular complications of COVID-19, the implications of delayed care on long-term health, and I am interested in addressing disparities, so we will discuss that very briefly, and I'll give you just a few insights on what we're doing in Louisiana and our Louisiana COVID-19 Health Equity Task Force. These are data from up to June 27th. As you know, they've now extended to approximately 211,000 persons who have died. But the main reason I'm showing this is that COVID-19 at present is the third leading cause of death in the United States behind heart disease and cancer. And we expected that there will be another 100,000 plus persons who may die before the end of the year. Before we go into some of the discussion, let's look at the nomenclature, coronavirus. Corona is actually Latin for crown, and it's because of the structure of the virus itself with these small areas of spike proteins that basically make it look like it has a crown. The term COVID-19 is actually an acronym. The CO stands for corona, VI for virus, D for disease, and then the year in which it was discovered was 2019, hence COVID-19. So COVID-19 is the name of the disease due to the coronavirus. Now, to a large extent, it is indeed a respiratory virus. It enters through the eyes, it can enter through the oral cavity, and it goes to the lungs. The main cause of death has been respiratory failure. But increasingly, we now recognize that it is more systemic. It goes throughout the body and can affect the vasculature or blood vessels in the heart itself. So along with getting COVID-19 respiratory symptoms, there are now mechanisms of cardiovascular symptoms, cardio for heart, vascular for blood vessels. Here we have a picture of the heart with the COVID-19 virus and the effects that it can cause on the heart from top to bottom. It increases oxygen demand. The body has to work harder. You can get myocarditis. Itis means inflammation. This is inflammation of the heart. Stress cardiomyopathy, which is an unusual form of heart failure where the person goes into heart failure simply due to the intense stress that they're under. Ischemia or infarction is chest pain and a heart attack. It's not necessarily because of a blockage in the vessel, but the stress that's placed on the heart. Cytokine release syndrome. The cytokines are inflammatory responses to the virus that actually can then lead to damage in the heart. Elevated pulmonary artery pressures are the pressures inside of the lungs themselves, and venous thrombosis or clots. Blood clots are a major part of what we see, especially in younger persons with COVID-19, and there are some data that blood thinners may actually help. So COVID-19 can cause heart attacks, It can lead to inflammation of the heart. We've even seen this in healthy young adults who are athletes, and it can cause blood clots. Now, the disparities that were mentioned earlier, this is a quotation that I gave to National Geographic, who asked me to comment on exactly why you have African Americans with more mortality from COVID-19. And I suggested it was a mixture of many difficulties faced by African Americans that may compound or extend the burden of the coronavirus itself. And these are being essential workers, not being able to work from home. There's no computer. You have to go into the job. Working in mass transit, where you come into contact with a lot of people, again, making it more difficult for you to avoid a COVID-19 episode. And these various variables are higher in African Americans. You saw earlier, you also see it in Hispanic populations, some Native American populations, working in service industries or essential jobs, using public transportation to get to work. Lack of access to early testing. One of the things that happened earlier was that we were using suburban malls, but people who may not have a private automobile were not getting tested as earlier. And within the African American community, and maybe somewhat within the Hispanic community, a historic distrust of the healthcare system because of previous bias. This is an editorial that I wrote along with one of my colleagues, Samar Nasser, and we came up with a name for the increased mortality. I call it a sentinel event. A sentinel event is used by the Joint Commission of Hospitals when they see that there's been retained foreign objects after surgery, people have fallen out of their beds and had a fractured hip. Then they look at that hospital from top to bottom because it's a marker that something is wrong. This increased COVID-19 mortality, therefore, is a marker that something may be wrong in our healthcare system. And these are some of the suggestions that I suggested at that time. I put a box just across a few. We now know telemedicine helps keep patients in contact with their providers with home blood pressure monitoring, encouraging healthy eating patterns. You can get home scales, thermometers, in some cases even oximetry. And it allows us to tell our patients of a need to seek emergency care. We know patients are staying home at times when they really need to seek emergency care because of a heart attack, stroke, or heart failure. So remote monitoring of cardiovascular risk has now become a large part of our care in COVID-19, and it allows us to stay in contact with patients in their home and in patients who may live in rural areas. We're now able to deliver care. It's probably not the best tool for a new patient, and because of the pandemic, there are now billable resources available for telemedicine. We can educate our patients, and I would hope in the future we even are able to loan or gift an automated blood pressure cuff so that they can stay in touch. This is from the American College of Cardiology. I'm a member of this association, and we also use this as an opportunity to remind our patient population that if you think you're having a heart attack or stroke, don't stay at home because of a fear of COVID-19. Call 911. It was mentioned earlier that I'm a part of the Louisiana COVID-19 Health Equity Task Force. This was something that the governor has suggested because we saw early on in the process disproportionate mortality or death, specifically in the African American community, but our Equity Task Force also includes persons who represent the Hispanic community, the Native American community, the Vietnamese community, which is another disadvantaged population here in New Orleans. And one of the things that we wanted to do was get reliable data on the degree and disparities of infection in various communities. We wanted to allow our communities to have the best practices and protocols. So we wanted to get some of that information about the appropriate social distancing, hand washing, wearing the mask, so that patients can protect themselves from the ravages of COVID-19. And we wanted to ensure testing availability. One of the things that we did was set up some walking areas where patients who did not have a private automobile could just walk within their community and get appropriate testing. We do a lot of messaging. This is an actual billboard that's up. You'll see these throughout Louisiana. And they basically look at a multicultural population so that people can see themselves. We want to target not only African Americans, but the Latinx population, the Native Americans, Asian Americans, and other minority groups so that they understand that it is not necessary to get COVID-19. If you take the appropriate steps, you can avoid the infection. And you actually see our signature at the bottom, the LA COVID-19 Health Equity Task Force. So I thank you for this opportunity, and I look forward to our question and answer session. I think the coronavirus has revealed inequities in our society which have been persistent, long-standing, and unacceptable, and we need to address that even after COVID-19 has been curtailed. Thank you.
Great. Thank you so much, Dr. Ferdinand. Very interesting presentation. For participants, you should see another poll pop up on your screens. This is to tee up our next presenter as we move to discuss state action on this topic. So the question asks, what actions, if any, has your state taken regarding telehealth services during the pandemic? And on this one, you can select all options that apply. And again, please feel free to go ahead and type answers into the chat box as well. As you are selecting your answers, I will mention that NCSL is tracking state legislation in response to COVID-19 across several different policy areas in our COVID-19 database, including actions on telehealth. We also have a webpage highlighting the health-related trends we're tracking in the database and a number of other publications on this topic. These resources are all available in the resource handout in the tab above the presentation. Great, and it looks like overwhelmingly most folks have enhanced Medicaid coverage, which we will hear more about in just a moment here. So thank you again for filling that out. Our next presenter is Jack Pitzer, a research analyst in NCSL's health program. Jack has been covering state action around healthcare access and coverage in response to the pandemic. He is our in-house expert on telehealth policy related to COVID-19. So I am delighted to hand it over to you, Jack.
Thank you, Kate, and thank you, Dr. Consagra and Dr. Ferdinand, for those earlier presentations. As you both pointed out, telehealth has been a major topic of conversation during COVID-19, to say the least, especially as it relates to continuity of care for patients with chronic conditions. So I'm excited to be here today to discuss telehealth state action during COVID-19. And just to briefly reintroduce myself, my name is Jack Pitzer. I'm a research analyst with NCSL's health program, and I cover access, cost, and coverage policies. So that ranges from private insurance issues to rural access to care to telemedicine and how all of these topic areas connect. So with that, let's go ahead and get started. So from the onset of the COVID-19 pandemic, there has been a flurry of policy actions regarding telehealth across all 50 states, DC, and Puerto Rico. And these are coming from executive branches, departments of insurance, Medicaid agencies, and more. And state legislators themselves have been equally as busy leveraging telehealth in wake of the pandemic. So since March of 2020, so right at the beginning of many state emergency declarations, we've tracked more than 72 enacted bills across 35 states, DC, and Puerto Rico, modifying their state telehealth policies, either temporarily during the pandemic or permanently. And these changes vary greatly. So for today's presentation, I'm going to unpack some of these state actions and discuss them in two buckets. First is enhancing private insurance and Medicaid coverage for telehealth, and then increasing patient and provider access to telehealth. And I just wanted to note that while the federal government has also pursued several changes to telehealth policies during the pandemic, especially as it relates to Medicare enrollees, I am just going to be focusing on state action today for sake of time. But if you do have any questions over federal actions, we're more than happy to take those during the Q&A session or get you connected with our NCSL colleagues in DC. So in order to ensure that patients have access to telehealth, several states have looked to bolster telehealth coverage for those that are enrolled in private insurance plans and those that are enrolled in Medicaid. So one way that states are doing this is by requiring payment parity for private health insurance plans. And this means that private insurers must reimburse for telehealth at the same rate as they would for in-person services. And according to the Center for Connected Health Policy, prior to COVID-19, 6 states had payment parity laws on the books, but that number has since grown to 20 states, either temporarily or permanently. But beyond payment parity, at least 15 states in D.C. have enacted legislation since March that enhance private insurance coverage for telehealth in other ways. And this can include actions like requiring private insurers to cover services that are delivered via telehealth if they cover those services for in-person consultations, and that is referred to as coverage parity. Or some states are limiting out-of-pocket expenses and cost sharing for enrollees that are receiving virtual care. Now pivoting to Medicaid, which covers a high number of enrollees with chronic conditions, executive branches and Medicaid agencies have been doing a lot of work to expand access to telehealth through emergency waiver authorities and other flexibilities. Legislatively, we've seen at least 10 states enact legislation bolstering Medicaid coverage for telehealth since the pandemic. And similar to private insurance, this means expanding access to different health services via telehealth, modifying reimbursement rates, and covering additional telehealth modalities such as audio-only phone consultations. For example, in Maryland, legislators enacted a bill that required the state to seek approval through the Centers for Medicare and Medicaid Services to establish a telehealth pilot program for their Medicaid enrollees with chronic conditions. And through this pilot program, Medicaid recipients can receive chronic conditions management services regardless of where they're located, and this will allow them to receive home-based care via telehealth. All right, with the coverage part covered, I'm now going to discuss a few state actions addressing barriers to telehealth access for both patients that are seeking services and providers who are delivering those services. So in order to mitigate any potential workforce shortages, several states have modified their licensing requirements for out-of-state providers delivering services to in-state residents through telemedicine. For example, in Kentucky, legislators enacted emergency legislation allowing out-of-state providers to deliver care through telehealth as long as that provider was in good standing in their state of licensure and certification. And additionally, the bill waived any requirement that a provider first must have an in-person visit before delivering services through telemedicine. Some states have also aimed to make telehealth more readily available to patients by allowing them to receive care in the comfort of their own home rather than having to travel to the nearest healthcare facility with telehealth capacities. For example, Minnesota enacted legislation that expanded the definition of originating site, or where a patient receives telemedicine, to include a patient's home. And the bill also requires private insurers and Medicaid to cover these services. Additionally, at least 4 states have leveraged federal and state funds specifically for enhancing broadband connectivity for telehealth. And this is a top concern in many rural communities where patients already face many barriers to care and experience higher rates of chronic conditions. In Mississippi, legislators enacted legislation that appropriated $10 million of federal CARES funding to establish the COVID-19 Broadband Provider Grant Program. And eligible providers can use these funds to expand rural broadband connectivity for improved distance learning, telework, or telemedicine capacity. Lastly, a growing topic of conversation is whether states plan to keep or not to keep the many telehealth flexibilities they pursued during the pandemic. For example, in Connecticut, they enacted legislation that extended their emergency telehealth changes until March of 2021. And state lawmakers there indicated that they first want to study the long-term impacts of telehealth modifications before they decide to make anything permanent. Other states, however, are already choosing to keep their telehealth modifications for the long haul. In New Hampshire, they enacted legislation in June that permanently incorporated the governor's emergency telehealth order into state statute. And while these are just some of the states that have already taken action in regards to temporary versus permanent changes, we do anticipate that this is going to be a continued topic of conversation, especially going into and throughout the 2021 legislative session. And lastly, I just wanted to reiterate that we have some really great resources at NCSL on COVID-19, and Kate mentioned them earlier. Our COVID-19 database, where we track any legislation that is introduced in regards to telehealth and COVID-19, and then our COVID-19 State Health Actions webpage, where we also have policy snapshots, and these are 2 policy snapshots here that include information on COVID and telehealth. And then we also track all enacted telehealth legislation in our Health Innovation State Law database. And with that, I'll go ahead and send it back to you, Kate, for any questions.
Great. Thank you so much, Jack, for that great overview of state actions and considerations during the pandemic. It looks like we have a question in the chat box, but don't forget, if you do have any other questions, please go ahead and type those into the chat box on the left. Before we get to some of our audience questions, I do have a few discussion questions that I would love to pose to our presenters here. You both touched on this in your presentation, but I was wondering if you could expand a little bit more on how this issue will impact states down the road as we look into next year. So I'll pass that question to you first, Dr. Consagra. Of course, understanding, there is no crystal ball here, but I wonder if you could provide some thoughts, just what you're thinking about as we're looking ahead at the wave of delayed care and the capabilities of healthcare systems responding to an emergency right now. So Dr. Consagra.
Thanks, Kate, for that question. And yeah, there's no question that, this new environment that we are living in, that is going to be with us for quite some time, and we're going to feel the repercussions of this for quite some time. Obviously, with COVID-19, that is something, even with a vaccine, is not going away. That is here to stay, and we need to continue to think about how we now manage and treat this new disease that is now a part of our daily lives. And then at the same time, when we think about chronic disease, that is still one of the leading killers in our country, and that also is something that we need to continue to work on for a healthy and resilient population. So that's not going away. And lastly, I think I'll just add to some of the points that Dr. Ferdinand made, which is that disparities in healthcare outcomes have also been present in our country for a long time, but COVID-19 has really put that in really an acute lens, and we see that even more, unfortunately, clearly now, even with the advent of this disease and the outcomes we're seeing in hospitalizations and the disparities we're seeing among different racial and ethnic groups. And so that also, particularly for African Americans, we're seeing a huge disparity, and that is something that we're going to have to think about and how to address and how we work to close those disparities as well.
Absolutely. Thank you. And Dr. Ferdinand, I'll pose the same question. If you could just provide any thoughts on how this issue will impact states over the next year.
Well, first, let's look at the present condition. Not only are many of the clients, especially the older patients, afraid of coming to a clinic situation or a hospital inpatient situation, they stay at home, they're not monitored, don't control blood pressure, become short of breath, have weakness, slurred speech, or they have a severe episode of chest pain, then they seek care. And where do they seek care? The emergency department. If you go to the emergency department anywhere, small town to big city, you're going to expend several thousands of dollars in care. And if you're admitted for what could have been a preventable episode, you're going to spend anywhere from $10 to $20 to $50,000 or more in care. So it's actually cost effective to do prevention in an outpatient basis. Now, the question is, what's going to happen going forward using that preventive approach with telehealth? I think it's going to be here to stay. The virus is not going to disappear. Even with the vaccine, it's going to take time before we have enough immunity that we don't have this large burden of cases. But we're also going to learn that there's now a site called validatebp.org, all one word, where you can get patients validated blood pressure devices. Some of them have Bluetooth and can be sent to an app where the clinician can actually see their blood pressures on a regular basis. We do that here at Tulane. There are actually scales that have a Bluetooth that can send that information. Patients know how to take their own temperature with thermometers. And as I mentioned, even patients who've been exposed to COVID-19 can purchase oximeters and monitor their oxygen saturation levels at home. And that clearly is going to be a more cost-effective manner of preventing disease, cardiovascular disease, but even complications of COVID-19. And that's going to be here for a while. So I would predict that we need to look at ways of maintaining telehealth, perhaps with some guardrails so that we don't have providers who may overuse it unnecessarily. But we even go so far as to facilitate either loaning or covering for devices for patients so that they can monitor and control their blood pressures. This is a Class A evidence in the U.S. Preventive Task Force, and it's in the 2017 American Heart Association, American Cardiology Blood Pressure Guidelines as Class 1. Out of office, telehealth is here to stay.
Great, thank you so much. And Dr. Consagra and Dr. Ferdinand, I believe you both briefly touched on this in your presentations and some of your slides, but I'm wondering if you could also expand a little bit more on how policymakers can get involved in this arena. So how would you recommend a state legislator get started, or who do you recommend they reach out to in their state? And I'll pose it first to Dr. Consagra.
Hey, thanks, Kate, for that question. One, I think when it comes to COVID-19, obviously there are lots of opportunities to think about how we're delivering the right public health messages. And in this case, we know what works and what's important to prevent disease transmission. And those are those things like wearing a mask and washing hands and maintaining social distancing. So any additional support in delivering those messages, I think, is something that our, legislators can get involved in. And then the other, obviously, when we think about chronic disease, there also, chronic disease in our country is underfunded compared to the incredible burden of disease that we have in our population. And so anything we can do to lend additional support to state chronic disease programs, and your state chronic disease director is a great resource to go to, is also another opportunity, and especially given the disparities we are seeing in chronic disease outcomes, and the fact that those outcomes then, again, impact other things that we are now seeing, like COVID-19. So incredibly important to think about what we can do up front to prevent chronic disease in the first place, not just, manage and treat it once you have it, but really work on prevention. So I think that's another opportunity for, state legislators to think about how they help support chronic disease in their state and through their state chronic disease programs.
This is Dr. Ferdinand. I actually agree. The extension of telehealth beyond emergency would probably be a good step forward. And if you're looking at monitoring chronic diseases, we already do this with glucose, with the glucometer, where the patients stick their fingers and monitor their glucose. We're going to be doing this more with blood pressure, with weight, with temperature. You're missing that physical exam. I think for the new patient, there may be a necessity that new patients are seen in an inpatient setting. But for chronic care patients, it may actually be cost effective, and it's certainly better than allowing patients to have uncontrolled risk factors and using the emergency department. In those states that have large rural populations where broadband may not be available, there are now some ways in which you can do telehealth using text messaging and conventional telephone. It's clearly not as good as the virtual visit with the smartphone when you can actually see the patient and have a more direct patient relationship. But even here in New Orleans, some of my older patients still have the flip phone, or they don't have access to a smartphone where we can do the virtual visit. And what I do is I'll call them the day before. My nurse practitioner will call the day before and ask them to have all their medicines lined up, get someone to check their blood pressure. If they have a scale, get a scale. If they don't, have a thermometer, get their temperature measured. Get your questions, write them out. And we can have fairly robust visits even without the availability of the internet. So I think it's here to stay. I believe it's a progress in the practice of medicine. For the new patients, perhaps we're going to have to mandate at least one in-person visit for new patients. But for chronic care, I think it's a really good model.
Great. Thank you both for your remarks on that. And Dr. Ferdinand, you mentioned telehealth just now and broadband access in rural areas. And this is, of course, an underlying theme here and a good segue into one of the questions that we got in the audience chat. So, Dr. Ferdinand, I'm wondering, with your work in health equity, if you could help out with this question here. The question is, do you know of any examples of equitable integration of telehealth into healthcare systems?
Yeah, in Iowa, if you go to the University of Iowa, I'm fairly sure you could probably find it on their website. They have systems, they use pharmacists who may be available to help patients in chronic disease management. And the Los Angeles barbershop study used the PharmD in black barbershops and did a wonderful job in controlling blood pressure outside of the usual clinic environment. Pharmacists now are not just the 4 years of college where they count pills and put them in a bottle, but they're PharmDs. They have 6 years of training, and many of them can get specialty training in disease management. I know for us as physicians, we're always a little bit cautious of other health professionals coming on our turf. But if you're looking at rural areas, some inner city underserved areas, then it may be other providers outside of the EMD who may be available to help these patients with chronic disease management. It, of course, can be in collaboration with a physician. There may be a mandate for them to see a physician at least once a year. But you can monitor type 2 diabetes. You can manage your blood pressure, stable asthma. A lot of chronic diseases can be managed by a well-trained PharmD.
Hey, Kate, this is Jack. I wanted to quick jump in on and say something based off of what Dr. Ferdinand said. I didn't even get, because of time, the chance to be able to get around to a lot of states that are looking at expanding access to telehealth to different provider types. And that's been especially prevalent for mental health providers, but also kind of like Dr. Ferdinand was saying, pharmacists, physician assistants, and such. It's been a major policy area as well. And I did want to plug that in our COVID-19 database, we also have a healthcare workforce tag in there, and then we have our scope of practice policy website that looks at scope of practice for a variety of providers and how that is important for rural access to care. And I can throw those in the chat too to make sure that people have access to those.
That would be great. Thank you, Jack. And that, following the vein of talking about telemedicine, we have another question in the chat box which asks, what are some of the limits of telemedicine for chronic disease care? So we've been talking a lot about, what are some of the benefits to help fill in these gaps in care during the pandemic. But I'll pose that question to both of our speakers, and maybe we can start with Dr. Consagra.
Hey, Kate, thanks for that question. Yeah, so there are some limits to telehealth. Obviously, you can't always replicate all the things you would do in an in-person visit through telehealth, and so there are some limitations there. Obviously for some types of, chronic care, there might be certain things that are required that you can only do if you're, listening to the heart and listening to the lungs, for example, which you can't always do remotely. So, there are those things that it does not replace. But at the same time, telehealth does provide the opportunity to, increase connections, to continue to do a lot where you can, a lot of that disease management, for example, things like glucose control. You can do that in partnership with the patient, monitoring that remotely and then sharing that with you through, a vehicle and helping to manage that via telehealth. So, I think there are some limitations, and it's not going to completely replace all of care that you can provide, but certainly does increase the ability for patients to be able to access care in this environment for sure.
This is Dr. Ferdinand. I clearly think there's some barriers. One is related to the new patient. As I mentioned, you can't get a good physical. You can't listen to the heart for wheezing, listen to the lungs for wheezing, listen to the heart for irregularity or heart murmurs. But for chronic patients whom you've already done an exam on, they're not giving any shortness of breath, they don't have a history of asthma, you've listened to the heart, you know they don't have a murmur or anything irregular, then you can maintain those patients pretty good. I think the biggest barrier is going to be for socially disadvantaged patients and patients who don't have access to the smartphone. Those patients, you're using just a regular telephone visit, and I gave you some of the clinical pearls that I use to try to make that a robust intervention, but it clearly is not as good as looking at the patient, and you can see distress, you can see shortness of breath, you can see the nasal flaring, the heaving of the chest. You can even look at lesions over the smartphone. So the smartphone is the best way. Perhaps at some time in the future we'll figure out some models where a person can be gifted a relatively inexpensive smartphone. We have to make sure we have internet access available. The same type of gaps that we're talking about in the use of telehealth are gaps that are being used with home learning for the public schools, where you have some people who have very good internet services, have 2 or 3 laptops in the home. The husband or the wife may be able to really help that child to access the electronic learning, and then you have other patients where there's no laptop or the internet is very weak or spotty, and the parents may not have the wherewithal to assist them with electronic learning. So those are the type of gaps that we need to address that clearly are gaps in telehealth, but it may be more cost effective to gift them a smartphone, make sure that there's a senior citizen center or a public health clinic where they can use their Wi-Fi code or something, some method to try to get around that, because I reminded you of what I said earlier. You cannot pay for an emergency room visit. An emergency room visit is thousands of dollars, and you're better off with a $35, $50 telehealth visit 2 or 3 times a year or even more frequently than one emergency room visit.
Great. Thank you so much. And it looks like we have answered most of the questions in the chat box, but maybe we can wrap up with this last question here about public communication. The question is, how can legislators get involved with public communications around getting routine care and staying safe during the pandemic? Are there any specific messages they can pass on to their constituents? And I remember, Dr. Ferdinand, you had that slide showing a billboard example during your presentation, so I wonder if you have any extra thoughts there.
Yes, we use billboards. We also are going to use the wraparound on the public buses, especially in the cities, where you can wrap the whole bus in a sign. We use the public stations. There are public TV stations on cable. There are airwaves, especially for Latino populations. There are Hispanic-speaking stations where you can get on with short messages. I just taped one last week, and my message was, we don't have a safe and effective vaccine thus far for COVID-19, but guess what? We can avoid the flu. Get your flu shot. Anyone who's over 6 months, and especially those who are 65 and older with diabetes, heart disease, chronic kidney disease, morbid obesity, those patients have marked increase in hospitalization and death due to the flu. So we use that as a messaging opportunity, and we're going to do that again in the public stations on cable, and we're going to play it as a voiceover on some of the radio stations. I think the messaging is good because people have to learn how to protect themselves. That's probably the first step in public health, is to get an engaged public to actually take care of their own health.
Great. And Dr. Consagra, do you have any final thoughts to add on any public messaging around this issue?
Yeah, I already mentioned a little bit earlier, but I think here, especially when it comes to COVID-19, we know what works, and we know the messages there around what works, again, around those things around face masks and washing hands and practicing social distancing. So I think anything to continue to encourage those messages is important for chronic disease care too, because we know, if we can decrease transmission, then we can all think about, other ways that we can interact, and that then folks are not feeling that they need to delay routine care. When it comes to chronic disease, again, emphasizing those messages around making sure that you are seeking care when needed. There's some great campaigns out there, for example, by folks like the American Heart Association that really speak to, if you're having signs and symptoms of a stroke or heart attack, to not delay, as was mentioned earlier, and to seek care. So continuing to emphasize those messages, and getting your flu shot, so important, especially now, has never been more important to get your flu vaccine. So that's another thing that we can all emphasize, especially right now as we start off that season.
Absolutely. Well, as we are nearing the end of the hour here, we will go ahead and wrap up. I would like to extend a final thank you to all of our presenters today. We really appreciate the expertise each of you were able to provide. And thank you to our attendees for participating in today's webinar. As a reminder, a recording and the presentation slides will be available on NCSL's website within the week. This concludes our webinar today. Have a great rest of your day and stay well.